A very good morning to you, Dr. Perlin, and thank you so much for joining today for this call. It's definitely an honor to have you on this platform and to let the audience know about your thoughts on different parts of healthcare based on your, such a rich, enriching experience that you have had. It's really an honor to have you here today. Starting with some of the few things that we would like to understand from you, one or two a little fun-loving kind of thing. So, if you think that at any point of time, if healthcare is kind of a mascot or it had a mascot, uh, what do you think it would be and why?
Well, Gaurav, first, it's a delight to be with you. Thanks for the opportunity. Look forward to seeing everybody at the IPSC conference. I'm not going to try to think of a mascot for all of healthcare. I'm going to think about our own organization, the Joint Commission and Joint Commission International. And in the United States, we love dogs. They're revered. They're pets. They're service animals. I would say that the mascot for the Joint Commission would be a dog. Why? Because we uphold the public trust and safety, whether it's international or domestically in the United States. And so on the one hand, there's part of our personality that's a little bit of a good, kind guard dog. But the part that we really enjoy is being a guide dog, where we can lead organizations, lead ourselves to better safety, better quality, better equity, better value healthcare.
Great. I think thank you so much for that. And for the fact that I have had an opportunity to hear you before, in multiple forums, I have seen that the way you have actually spoken a lot about technology, AI, and we are actually bringing a lot of that to Joint Commission and JCIA now. I think based on that, based on your technology brain, if you have to kind of pick up or invent a new medical device, just for a fun purpose, what would that be?
Well, I would love to have an exercise robot buddy. I'm not as disciplined as I should be in terms of exercising, and something that sort of prodded me on, would go out running with me, push me a little harder. So think some sort of humanoid exercise robot buddy would be my fun technology invention.
I wish we can do something like that, but getting on to some of the key questions that I thought we would discuss today. The first definitely on AI. AI is the in thing that everybody has been talking about. It's kind of everywhere, especially on social media, and people are actually using it a lot. And I know that you are one of the people or one of the persons who definitely have got a lot of knowledge and an understanding of what the world is talking about. So how can AI-driven healthcare can actually balance ethics, technology, and medical accuracy to improve and enhance patient safety?
Well, this is such an important question. Thank you for that. AI is really the defining technology for the century. And in healthcare, it has the opportunity to improve quality, safety, productivity, equity, so many of the desirable attributes. And healthcare is a target-rich environment for improvement. In the United States, Professor Andy Arbach at the University of California, San Francisco, in January of this past year, published a study that showed that 23% of patients who deteriorate or die in hospitals do so because of a missed or a misdiagnosis. And the amount of information that contemporary clinicians have to think about is overwhelming. And the opportunity for AI to augment that is tremendous. Let me give you an example. At the turn of the 20th century in the United States, when phone numbers came into place, they went to the psychological literature to see how many variables humans could remember. And it turns out we can do well between 5 and 7 variables. And so US phone numbers were 7 digits. And the number of combinations is actually called factorial. And that's 7 times 6 times 5 times 4 times 3 times 2 times 1, which I'm sure you've already calculated as 5,040. In the average intensive treatment unit, there are about 300 orders in effect and about 1,000 new pieces of data every hour. How big is that? That number is so big that it's actually larger than the number of particles thought to exist in the universe. And so we really need these sorts of technologies to help us deal with all of the data. Now, to making sure that these technologies do what they're meant to do, we need to have, I believe, two features for assurance. One is a testing of the technology, and that testing should occur in three domains, and that testing needs to interact with a governance process in the environment in which the technology is being used. And so the testing and governance need to address three things. One, it should address that the mathematics of the algorithm work, that is, that it's technically workable algorithm. Two, that the evidence used is correct clinically so that there's domain accuracy. And third, that there is cultural competence to understand if there are any training biases in the data set that we use to train. Now, parenthetically, I would note that I'm really talking about AI that's based on generative models. We've been using a lot of AI for a long time. And when we say AI, we really mean a lot of different things.
Really very interesting. And I think when the audience is going to listen to this, they will agree to what I said before you started answering, that you are one of the persons who kind of knows the most, and one of the people who can actually really connect on what are we talking, what is it that it means really in terms of healthcare. So thank you so much for sharing that information. So Dr. Perlin, if we have to switch gears a little bit from AI and move towards understanding, how do the partnerships across academia, industry, and government largely play in advancing patient safety on a global scale? If you could share a little bit on that, please.
Well, Gaurav, thank you for your very kind comments. You know, we have two simultaneous challenges. We want guardrails on the one side that prevent us from unintended consequences of AI, but we don't want guardrails on the other side that are so overly rigid that it really stifles what is the defining technology of the century. And so first, you know, to really get the sort of utility we want, we need to train models at scale. And some of the great work that Apollo is doing with the clinical information engine is just remarkable because there's a data set that can really train models to respond to a variety of situations. But there is so much to capture from the experience of healthcare that we just let go to waste. So, for example, you know, think about all of the latent knowledge that's embedded in what we might call the collective memory of healthcare. Think about all the patients that have been treated for cancer or infectious disease. Think about all the variations and medications they might have had. In those data, in that collective memory, there are probably clues to what's best and also what's bad. But we just don't know that yet. And so we really need to use and develop models not only for real-time care and improvement, but for drug discovery, for new uses of drug. And this, as you indicated, has to involve partnerships across academia and industry to be able to scale the technologies, and relationships with governments so that we have the appropriate guardrails that help prevent untoward and unintended consequences on the one hand, but facilitate an understanding that we don't want stifling overregulation that would thwart the progress that's so desperately needed.
Thank you for that. If we have to look at, you know, Joint Commission as an organization with that deals with so many hospitals in US, and then Joint Commission International that's really present worldwide. And you know, so from your experience largely at the organization, what do you think are the most impactful trends that are actually shaping the future of healthcare quality?
We've been discussing, certainly AI is at the top of that list. In the last couple of years, that's our colleague, Dr. Jeffrey Braithwaite, who introduces the concept of Safety 2.0. He and I agree that it's too easy to say, well, healthcare is just like aviation. Not really. The entire physiology of a plane or in the event of an accident is really understood. It's very much a closed system. In contrast, healthcare is much more dynamic, much more complex, different people and entering and exiting the interaction with the patient. But Safety 1.0 says, let's look for all the failure modes and ask exclusively the questions, what went wrong? Safety 2.0, as Braithwaite argues, is really about asking why things go right in a complex and dynamic environment. Healthcare is really a complex adaptive system, and that means that there are independent actors or agents that may act similarly or differently under the same circumstances. And so the permutations of how something will play out can be very variable. And understanding how to build robust success is really behind Braithwaite's concept of safety 2.0. He and I agree that the best of all worlds is looking for failure modes in safety 1.0 and looking for success modes in safety 2.0, something that he terms safety 3.0. I think that's really one of the most fruitful opportunities for improving the future of safety and healthcare quality.
Yes, I agree to you, because I think in healthcare, we have really taken few concepts from aviation, kind of implemented it where we could. And one of the very shining example is of having a timeout process that largely, a lot of us actually learned about that through JCI standards and understood that what exactly it means. So I think, yes, you are absolutely correct. It's also great to look at why are we succeeding and what are those factors that will help us to largely sustain those success points and probably move towards being high reliable organizations in the due course of time.
Well, thank you for saying that. If I might, I can't tell you the number of times that I go to hospitals around the world. They said, we're so glad we implemented the timeout. We would have taken out the wrong kidney. We would have taken out the good kidney while the kidney with cancer would have been left in. If not for that, it saved that patient. So that's really gratifying. And thanks for your leading work in that area.
Yeah, thank you. If we have to kind of use, medical expertise that is there with the clinicians and the nursing teams, and if we have to kind of combine that with, again, since a lot of data that's available, with data analytics, we need to use, let's say, behavioral science. How can we combine these three things together largely to address, which are our global challenges like sepsis, like maternal mortality, infant mortalities. So how could we kind of combine these 3 pointers and see how can we make a difference?
Well, let me use one example from India and one from the United States. And I think in terms of the behavioral science, what could possibly be better than when the patient and the clinicians, the doctors, the nurses are on the same page and literally on the same page. And so I think the work you're doing with the Apollo Clinical Information Engine is really remarkable. It helps orient patients to what to expect and what might be appropriate for their condition. And it orients clinicians to what's best for that particular case. And that really brings together patient and care team on the same page. What a wonderful example of behavioral science leading to a higher quality, safer, and more satisfying experience of care. Now, let me switch to one in the United States. In my alma mater, HCA Healthcare, we had done everything we could manually to improve sepsis care. And sepsis is sort of a final common pathway for total body failure, often precipitated by an overwhelming infection. And every hour of delayed diagnosis results in an increase in mortality of between 4 and 8%. And so if you can turn the clock back, you save lives. And using deep learning, we were able to assess things that we knew about as markers of sepsis, as well as things we never would have thought of, demographic data and the like, transfer data, and be able to tee up for clinicians, not a diagnosis of sepsis, but a set of things that the computer saw and say, hey, the computer is seeing this, 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 and this. Is it possible that your patient has sepsis? And by asking that question, we didn't tell the physicians and nurses and alienate them by saying, we see something that you don't, but rather, here's what we see. What do you think? And sometimes, as they say, better lucky than smart, because in that process, we made that advanced analytic, the artificial intelligence, intelligible to the care providers, and they took it up with relish. In fact, their often stated comment was, this is what makes using an electronic health record worthwhile. And in the process of using that technology, we turned the clock back in the diagnosis of sepsis, and over 5 years, saved over 8,000 lives. 8,000 people who got to see in a new year, welcome a child or a grandchild, celebrate an anniversary. So that was really gratifying and a great combination of bringing together medical expertise, data analytics, and behavioral science.
I know it's really very gratifying, and I mean, I'm when I'm listening to it, I'm feeling so so great about it. But thank you for sharing that as well. Uh, COVID-19, I think, was an era that history will never forget. Unfortunately, uh, all of us, I think, each one of us really went through a lot at that point of time. Especially people who have been in healthcare, they have seen a lot. And I think we have learned a lot during COVID. We have also, I think we should also dedicate the whole lot of digital transformation that we are seeing today, which may not have happened even for the next 10 years, have happened because of COVID-19. So if we have to pick up some lessons from those kind of public-private academic collaborations that, happened or during COVID-19, how do you think that could largely shape the interdisciplinary healthcare solutions for the future?
So as the old saying goes, those who fail to learn from the past are doomed to repeat it. And we learned a lot very quickly in COVID. Some of that was building on things that we knew. In my organization, we had set up an infrastructure for large cluster randomized trial, randomizing hospitals by, to a particular type of protocol. And in that process, we had done some great work in infection prevention. The reduced MRSA trial, as an example, brought together 43 hospitals organized into 3 different approaches to reducing MRSA and other multi-drug resistant infections. And even though the outcome that was published in the New England Journal was that we reduced MRSA and other high-level infections by nearly half, to me, the real headline was that 43 hospitals did in 18 months what would have taken one hospital 64 years. And so building on that platform, as well as pre-existing emergency management, we realized that in my healthcare organization, we're going to be taking care of an awful lot of COVID patients. In fact, by the end of 2020, our organization had cared for 121,000 COVID inpatients. And so working with academia and government, our Agency for Healthcare Research and Quality, we said, hey, we think these data will be useful for accelerating the understanding of COVID and its treatment. And indeed, by the end of 2022, we'd cared for over 400,000 COVID inpatients. And the aggregation of their data for learning allowed us to very quickly dive into studies of what worked and what didn't. For example, it validated the notion of proning, that is, placing patients on their belly to improve lung function and avoiding the need for a mechanical ventilator. It allowed us to understand if a patient had to go onto a mechanical ventilator, what were the best settings or parameters to prevent lung injury. It allowed us to look at outcomes in pregnant women who presented with COVID at the same time. In fact, there were today over 50 publications that came from this public-private academic partnership and over 20 grants answering fundamental questions. And so I think to your point, the fact that we did that really sets a model for what can be done to accelerate learning, should there be, as regrettably there quite likely will be, other pandemics or other situations that require the world or countries or regions to learn at scale and also at speed.
Thank you for that. And I'll not take much time. I would go to the last question now for you. So International Patient Safety Conference, IPSC, is now actually the largest conference that focuses on patient safety and spreads the message across around the world. And we have been really very lucky to have you as a speaker for the conference. What excites you the most about IPSC, and how do you see it influencing global healthcare initiatives?
Well, first, let me say what an honor it is to be there. Thanks to Apollo for sponsoring such an important conference. It's a wonderful event for learning. It's where I first met Dr. Braithwaite in person, as a matter of fact, having referenced him earlier. But what I personally also enjoy is seeing the worldwide approaches to quality. and with Apollo's sponsorship, the opportunity to dive really deeply into the great work that Apollo is doing. So I look forward to seeing friends and meeting new colleagues at the conference coming up. And it's just an honor to attend. Thanks for the opportunity for this conversation today.
Thank you so much for your time. For me, it's as I told you in the beginning, it's really an honor to speak with you, and actually learning from you as well. I did learn a few things during this conversation. So thank you so much for your time. I know you have a very, very busy schedule, but you took out time for this discussion and for these helping us understand some of the key things or areas that are very critical in today's healthcare to make it globally safer. So thank you once again, Dr. Perlin.
Thank you so much.